Hey everyone, welcome back to Friends with Your Benefits, where we make the world of healthcare a little less complicated. I'm your host, John Coleman, and today we're diving deep into the world of 340B drug pricing. And this isn't just some boring pricing policy, it really impacts what we all pay for healthcare. So, with that, let's dive right into it. So, what exactly is the 340B drug pricing program? To begin with, it was established by Congress in 1992 with the goal of helping safety net providers such as hospitals and clinics in low-income areas receive outpatient drugs at a deeply discounted rate with the goal of stretching federal resources as far as possible. Now, this is important because certain hospitals and clinics in low-income areas may not be fully compensated for their care, and by having this program in place, it allows the hospitals to purchase these drugs at a deeply discounted rate. Here's how the program works at a high level. Drug manufacturers are required to offer certain healthcare organizations deeply discounted rates on their drugs in return for the drugs being eligible for coverage under Medicaid. This means that certain organizations, also known as covered entities, can purchase outpatient drugs at discounts ranging from 20 to 50% off the average manufacturer price. So, what are some examples of drugs that are eligible for the 340B drug pricing program discounts? Some examples include Truvada, a medication that helps with HIV. In the cancer space, Keytruda is an ultra expensive medication that may be eligible for a discount. If we look at diabetes, Trulicity could be eligible. And lastly, if we look at cardiovascular, the medication Eliquis could be eligible for a discount under the 340B drug pricing program. These are just a few examples, but in essence, if it's an outpatient drug that's FDA approved and it happens to fall under the HRSA database, likely the outpatient drug is eligible for the 340B pricing program discount for covered entities. So, John, these discounts sound great, but we know there's no such thing as a free lunch. So ultimately, who's footing the bill for the discounts under the 340B pricing program? Well, here's where things get interesting. The hospital nor the patient is directly footing the bill, and ultimately the discounts fall on the drug manufacturers, and they need to, by law, provide these discounts in order for their drugs to remain eligible for Medicaid reimbursement purposes. However, this is where things get really interesting with the program. Even though the hospitals are able to acquire these medications at a very deeply discounted rate, they are not required to pass this discount along to consumers, patients, or even health insurance providers. So in essence, they could purchase these medications at a deeply discounted rate, but they can bill insurance at their full market rate. And note that there's no specific requirement stating that these savings need to be passed along to patients to reduce their out-of-pocket cost, nor do these discounts need to be used to serve the community in any specific way. So let's address some of the criticisms of the 340B drug pricing program. So the first criticism is that the program incentivizes the use of higher costing drugs. As the discount is based on a percentage of the average manufacturer price, hospitals are definitely incentivized from a financial perspective to use higher costing drugs, as they're able to generate a much higher profit margin compared to using lower costly drugs or biosimilar medications that tend to be significantly lower in cost compared to their brand alternatives. Number two, there's an incentive for the hospitals to shift the site of care to the outpatient hospital setting, which tends to be significantly more expensive compared to the lower site of care vis-a-vis the physician's office or an outpatient infusion center. And typically, When medications are dispensed in those settings, the cost is a fraction of what it is in the outpatient hospital setting. But because the hospitals are getting a profit windfall, there's an incentive for them to push patients to use the outpatient hospital setting because they will get a higher reimbursement rate and profit margin on these drugs. Number three, as a result of the program, hospitals will sometimes acquire independent physician practices to increase their market share and ensure that more patients are covered and using medications under the 340B pricing program. And this process definitely reduces competition and can increase the overall price of healthcare. Let's talk about how self-insured employers are impacted as a result of the 340B drug pricing program. So first, potentially self-insured employers could be overpaying, and they could be overpaying because the hospital systems are not required to pass along the discounts, yet the hospital systems are able to charge their full market rate. So as a result of that, the self-insured employers and the commercial insurance market in general can be overpaying for the cost of these medications. The second way this impacts self-insured employers is that drug manufacturers are not going to take these losses on the chin. So what they're going to do is they're going to need to increase their prices in the commercial market to make up for their losses as a result of the 340B pricing program. So in essence, what could be happening is that self-insured employers are hit twice. They're hit first, as I mentioned before, with the increase in cost from the hospital systems. And then secondly, in the general commercial insurance market, the drug manufacturers are going to increase the price of the medications to make up for their losses as a result of the 340B program. So in essence, self-insured employers lose and lose big time as a result of the 340B drug pricing program. The last criticism of the program is the impact on patient cost sharing. So based upon the most recent Mercer survey of employer-sponsored healthcare, just under 40% of employees are enrolled in a consumer-directed health plan out there. And as a result of being enrolled in these plans, typically these employees have higher deductibles compared to PPO or HMO programs. If you happen to be enrolled in one of these programs and you receive care at a covered entity that is eligible for a 340B pricing program, you may have a higher out-of-pocket cost and not receive any of the financial benefit of your hospital system receiving these discounts. So you could potentially get a bill in the mail for thousands of dollars, even though it might be costing these hospitals pennies on the dollar to receive the drugs as a result of the 340B pricing program. So the ultimate criticism is that patients don't necessarily benefit from these programs, only hospitals do. And there you have it. While the 340B pricing program is very complex, today we ultimately just scratched at the surface of it. Its ultimate goal is noble, as the purpose is to help underserved communities. But on the flip side, it's definitely had a lot of unintended consequences that can increase the cost of healthcare for those outside of the covered entities. Now, we want to hear from you guys. Is the 340B drug pricing program in need of serious reform or just changes along the edges? Comment below.